Hi everyone! I'm sure you've noticed changes in the evaluations you are completing on our residents. I've created this brief slideshow to review the changes and provide you with guidance on how to choose the rating level for the residents you're evaluating. This first audio slideshow will use one of the new milestones from the ACGME to illustrate the recommended approach to completing an evaluation on your residents. The milestone we will work with today is PC1, or Patient Care History. In the coming weeks, further slideshows will outline other milestones. Thanks for watching. To start, I wanted to quickly review milestones in general. So first, what are milestones? Milestones provide a framework for the assessment of the development of a resident and the necessary elements to be a competent physician. Milestone ratings are synonymous with moving from novice to expert through training. There's no predetermined timing for a resident to reach a certain level. Everyone progresses at their own rate. Our evaluations are designed to assess our residents as they move from novice to independent doctor in each of the milestones. With input from your faculty, evaluations were designed to capture some of the important knowledge, skills, attitudes, and other attributes expected of the resident when rotating with you. In line with the new ACGME milestones, rather than expecting that most residents are a 3, as we suggested in the past, we're asking you to use the descriptions on the evaluation tool, combined with your observations, to choose the level where the resident should be rated. By assessing how a resident is doing, we can then offer support, help them stretch their skills, and reflect on how our program is doing educating our residents. I chose to start with PC1 as an illustration since many of our evaluations will ask you to rate your resident's history-taking ability. I will walk you through some hypothetical examples to help you as you assign ratings to your residents. So when the ACGME asks us to evaluate history-taking skills, they want us to assess whether the resident can competently interact with patients from diverse backgrounds and consistently use all available resources to obtain a comprehensive history. Over time, an intern should move from taking a history for simple problems to more complex situations. For example, let's think about when you're evaluating your first resident, resident Y. Since everyone grows at their own pace, you don't need to consider whether resident is an intern, second, or third year. Therefore, for now, we'll consider everybody to be a resident. So it's the end of your time on service. You've heard resident Y present multiple patients and have read multiple H&Ps written by resident Y. Now you must choose a rating on Patient Care 1 or their patient history skills. You start by reflecting on the cases that the resident worked up. So you think about the first case that your resident worked up with you. The patient was a 50-year-old with community-acquired pneumonia. You remember the resident asked about when symptoms developed, the presence or absence of fever, the description of the cough, the presence or absence of shortness of breath, whether the patient smoked, traveled, or had exposure to ill contacts. You didn't need to ask any additional questions for this common presentation. So given this, you're comfortable from the history obtained that this patient has community-acquired pneumonia with usual pathogens. You consider this to be a simple, common diagnosis for the medical service. So how would you rate this resident? As you look at the evaluation tool and read through the columns, you decide this resident is at least at level 1. They can elicit a history for a common presentation, and maybe a level 2, given that the resident did this with little input from you. However, for this patient presentation, it wasn't required that the resident seek more information from other sources, and this is a necessary skill to reach level 2. So you're not sure if the resident would be able to do this. You need to reflect on more cases before assigning an overall rating. So for now, you might rate this resident 1.5 in between columns until you're certain that they can independently seek information from other sources. So next you reflect on this next patient who presented with chest pain. The resident asked about when symptoms developed, what the patient was doing at the time, how long the symptoms lasted, how often the patient has been having the symptoms, what their risk factors are for heart disease. The patient told the resident they're uncertain if they've ever had any cardiac tests in the past. So the resident called the patient's PCP and found out that the patient had an exercise stress test 2 years ago for exertional shortness of breath without chest pain, and it was negative. You didn't need to ask any additional questions for this common presentation, and you're comfortable from the history that was obtained that you can choose an appropriate diagnostic plan. Based on this patient, this resident is at least at a level 2. They can elicit a history for a common presentation and are able to independently obtain data from secondary sources. Now you think about a patient that presented with right upper quadrant pain and some mild jaundice. The resident asked about when the pain started, associated symptoms. They obtained a history that the patient had a cholecystectomy 10 years ago. The resident asked questions related to possible malignancy, substance misuse, and potential medications that can cause jaundice. Because of the cholecystectomy, the resident didn't ask any further history related to possible biliary colic. The resident also does not ask about recent medications that might include over-the-counter or herbal products. You need to remind the resident that retained common bile duct stones can present with obstructive symptoms and that some herbal products have been implicated in jaundice. So you think this is a more complex patient problem given the extensive differential. You decide this resident may be a level 2.5 for this presentation, but because they omit some questions for more complex presentations, they're not a level 3. Therefore, you rate the resident as a 2.5 because they meet the objectives of column 2, but not all of the objectives of column 3 yet. Now you think about a patient who presented with an X-ray consistent with heart failure. The resident asked about associated chest pain, shortness of breath, PND or orthopnea, and adherence to medications, but did not ask if the patient had been experiencing any palpitations. The resident checks with the PCP to see if the patient's blood pressure has been well controlled, therefore considering diastolic dysfunction as possible cause. When you question the patient, they tell you they've had a few episodes lasting about an hour where they had palpitations, where their heart felt like it was jumping out of their chest. It's clear that the resident didn't consider possible paroxysmal atrial fibrillation as a trigger for the heart failure presentation. Given the questions the resident asks, you believe they are at least at a 2.5, given that they checked on the blood pressure control from the PCP, but they're not at a level 3 since they didn't ask questions that may have led to diagnosing paroxysmal atrial fibrillation as the etiology for this complex presentation. Considering the multiple cases, you're comfortable rating this resident at a level 2.5. When you give the resident feedback, you can refer back to the milestones, show them the columns, and point out the skills that they have acquired and what they need to do to move on to the next level. You might even help them move forward by suggesting a resource like From Symptom to Diagnosis by Lang to help them build their illness scripts for the types of presentations they're seeing. To end, I wanted to summarize a few important points. First, remember everyone grows at their own pace. Second, you're not giving grades, you're guiding growth and improvement. Third, please use the descriptions and examples on the rotation evaluations to assign a level. This will make it easier for you and more objective than your general gestalt. And lastly, please provide feedback. Using the descriptions can help you provide actionable feedback. You can refer to the evaluation levels and say, this is where you are, this is where you need to go, and this is how I can help you get there. Thank you for watching, and if you have any questions at all, please feel free to reach out, jennifer.jeremiah@brownphysicians.org.